Good morning and welcome everyone. First of all, I'm sorry for my voice. It's not because of yesterday's football match, but rather I'm a bit getting out of a cold. But I will try my best to present my topic on novel strategies in advanced interventional cardiology. My name is Réka Ehrenberger. I'm a PhD student in cardiology and a pediatric resident. My vision is to improve patient care in Hungary and worldwide through evidence-based innovative healthcare solutions. For this, I would like to provide forward-looking and novel scientific results. Here are my specific goals. These are my ongoing projects. Both of them are with the methodology of meta-analysis and systematic review and meta-analysis. The first one is dealing with the optimization of the treatment of calcified coronary artery lesions, and the second one is dealing with or focusing on the most optimal timing of left ventricular unloading during the ECMO treatment. So first of all, my first study is with the calcified coronary artery lesions. But why is it important? Calcified coronary arteries are also called end-stage coronary diseases, and it's not by accident. The calcification in the coronary plaque can clearly define the adverse event rate and the overall mortality rates. And because of the resistant plaque burden, these calcified coronary cases require additional treatment modalities, so-called plaque modification techniques. We have multiple options there. First of all, the rotational atherectomy, or other kind of modified or dedicated devices like the modified balloon types, like cutting or scoring balloons. The problem is that the evidence is really scarce on what we use, how we use them, and when to use. So our aim was to examine the effectiveness of these treatment methods. In this study, we were investigating patients who were treated with moderately or severely calcified coronary lesions and were treated with rotational atherectomy as a baseline. We compared the modified balloons to the workhorse devices, or so-called plain balloon types, to each other after rotational atherectomy treatment by the analysis of several safety and efficacy outcomes. Our primary outcome was the major adverse cardiovascular event as a composite of acute coronary syndrome, repeated revascularization, in-stent restenosis, stent thrombosis, and all-cause mortality. This is our flowchart of selection. We ended up with 8 eligible articles for the full text and for the analysis. This is the baseline characteristics table of the included studies. I wanted to draw attention that we had 2 RCTs. The rest of the studies were observational ones. And here is the main forest plot of ours and the results of our primary outcome of MACE. On the left-hand side, you can see the forest plot. On the right-hand side, you can see the risk of bias assessment and certainty of evidence assessment results. We used the effect measure of odds ratio, and what we could see here is that in case of a modified balloon applied after a rotational atherectomy treatment, patient could so the MACE rate could be almost halved in that patient population. Unfortunately, this result didn't reach significant statistical significance, but I also want to highlight a quite high heterogeneity. As we dig deeper in these articles, we found that the analysis of the lesion characteristics wasn't really, so they differed between the studies, and sometimes they included moderate and severe cases as well, and they mixed the results together and didn't report them separately. So we decided to have another analysis with only the subset of articles that included only severely calcified coronary lesions to have a clearer picture. Here we used again the effect measure of odds ratio, and we could see not just clinically but statistically significant results as well, seeing the benefit of modified balloons after a rotational atherectomy in case of a severely calcified coronary lesion treatment. Also, we had some safety outcomes, procedural complication times like slow flow, no reflow, and the coronary perforation rates. What we could see is that there was no difference between the two groups, which is really exciting because probably you all know that modified balloons are considered a more aggressive treatment method than plain balloon types. So it's really important that they didn't increase the risk of safety or procedural complications. So for our overall conclusion, we can say that patients, and especially those who are treated with severely calcified coronary cases, can benefit from the application of modified balloons after a rotational atherectomy treatment, while not increasing the risk of procedural complications. We wanted to draw attention on the need for objective evaluation in lesion characteristics, mostly using intravascular imaging techniques. This is the status of our manuscript. We decided to redo the systematic search because of the emerge of new studies, since our initial systematic search, and we want to resubmit it to a previously targeted journal. Moving forward to my second study, which is dealing with the veno-arterial extracorporeal membrane oxygenator. This is a device, which is a really important part of the complex care when it comes to treating critically ill patients and cardiogenic shock patients. The problem, one of the main problems with that is that it can cause retrograde aortic flow and lead to insufficient decompression. So the hospital mortality rates of this critically ill patient population is really high even nowadays, but it is proved that it can be reduced by the use of some kind of devices. This is called the left ventricular unloading or venting devices. We have multiple options there, but again, the problem is that we don't really know what to use, how to use, and when to use them. We wanted to answer the last question, the one part, and we investigated patients who received VE ECMO, and we compared the prophylactic unloading strategy to the therapeutic unloading strategy by the analysis of several safety and efficacy outcomes. We ended up with 15 eligible articles, but only 12 included the data that we could use for the quantitative analysis. Here you can see the baseline characteristics of our included studies. We had 2 RCTs, 3 that could use propensity-matched data, but also the types of VE ECMO and type of unloading. Also, the usage of backflow cannula was really different in the included studies. Also, we included 2 studies that had data on a pediatric patient population. This is the result of our primary outcome, the 30-day survival rate. We used, again, the effect measure of odds ratio, and we could see not just statistically significant, but clinically really relevant results, showing that using the prophylactic strategy during VE ECMO in the left ventricular unloading, the 30-day survival rate almost doubled. This is the analysis of one of our safety outcome, the limb ischemia, which is a great deal in case of VE ECMO treatment. What we could see is that in the prophylactic group, the limb ischemia rate was significantly lower. For overall conclusion, we can say that the prophylactic use of unloading devices during VE ECMO treatment significantly improves 30-day survival rates, but there is a big need for comparative analysis on unloading devices as well. These are my additional activities. I want to draw attention that I had an article, a review article on the management of VE ECMO, which really complements my second meta-analysis. And here is the summary of my 2 presented projects, which are for the goal to help practitioners with evidence-based healthcare decision-making. I'm confident that my presented and future research can adequately serve this purpose. And thank you for your attention.
First of all, I want to congratulate you for this presentation and for the courage to touch such subject, because it's not long time when this kind of treatment was implemented. And in our clinic, in our department of cardiology in the emergency hospital in Bucharest, we were among the first team who touch such treatment. So it's, in a way, it's very difficult because suppose not only a very good selection of the patient, but in the same time to assess the possible complication. Do you want to say a little bit, to tell us about the risk of this method of the rotablation?
Yes, of course. So this is basically, who doesn't know, this is a drill, like a little drill to so modificate the calcified lesions, and these particles can go through the little coronaries and can cause maybe also the slow flow, no reflow, as I showed, and also can cause maybe embolism. Sorry. But these particles are so small that it is really rare. Also, it's a quite aggressive treatment method, so we can also see dissection or coronary perforation. This is why we address these kind of complication rates as well. Unfortunately, we can't really see that in our department, or it's really rare. And also in the articles, the dissection was really rare, so we couldn't really study that because of the low sample size. But the coronary perforation rate was quite okay. So, you know, it's a big issue, but it's quite rare in our department and in the articles as well.
Thank you. It depends very much also of the experience of the operator. Yeah. Thank you so much.
So congratulations to this presentation. I have a question for your first topic. How do you define the moderate and the severe lesions? And in the articles, how did they image it with computer tomography, angiography?
Thank you for the question. It was a really great deal because the articles really differed on how they characterized a moderate or a severe calcification. Most of the studies only based the decision on radio opacity, so the angiogram, what they saw. They said it's moderate if we only see the calcification when the heart moves, and we see without the injection of the contrast. It was severe when they saw it in a frame, so they saw it, the calcification on the angiogram and not the heart moving. But some of the studies included intravascular imaging techniques as well, like intravascular ultrasound or OCT. There was one study that included OCT and two studies that included IVUS or intravascular ultrasound, and based the decision or the differentiation on that. So yeah, it was a great issue. This is why we wanted to draw attention to the importance of intravascular imaging techniques. Of course, we can't always use them because they are really costly and also time-consuming to use them. We don't really have the opportunity to use them in every case. But in our department, we use at least IVUS in case of a left main calcified lesion. So this is really important, and it was a great confounder in our meta-analysis. This is why we wanted to separate the severely calcified cases and have a separate analysis, including the subset of these articles. Thank you.
Thank you. So first of all, that was a really nice and well-structured presentation, and congratulations for that, and also the papers. I'm not a big cardiologist, I would say. I have only tangential information about these issues, but I'm interested in whether there was a possibility to make a subset analysis on the diabetic patients, because diabetes itself makes the plaques vulnerable, much more vulnerable, and maybe the side effects, or I would say the complications, will increase. So was there any information about these issues?
Yeah, we gain information about the people or the patients included, and we also extracted data on the patient characteristics and comorbidities, but we weren't able to do a subgroup analysis based on that, because not every paper included information on diabetic patients, or not really distinguish them, or they pooled the results together, and hence we didn't have the patient data, the individual patient data. We couldn't really do that, and we didn't have only articles that only assess the results on diabetic patients. But yeah, it's really important, and we tried to, but we couldn't really because the absence of the individual patient data. Thank you.
I have not a question. I have only a suggestion, because I am impressed. How do you manage this topic? Speaking about the evaluation of the severity of lesions, and to take the decision to do or not to do an atherosclerotic rotablation, you can use artificial intelligence now, because there are some modules already done, starting from the imagistic evaluation, and to tell us if we can do or not can do. Yeah?
Yeah, thank you. Actually, in our department, there is a study on that, and they assess the CT angiography results or coronarogram results, and they want to see whether it's correspond or not. So, yeah, thank you.
I really congratulate for your results. I'm a cardiologist, and I also work in the field of interventional cardiology, so I know this topic very well, and I know how difficult it is. And my first question, because I've got a couple of questions, my first question is that do you have your own results on the topics? I know that Professor Édes is doing a lot of things on this field, so because it's very important to have your own data and you compare to the literature.
Yeah, unfortunately, on this exact topic, no. They had previously, I wasn't on the working group yet, but they had a study on the VE ECMO, where they assessed some kind of prognostic factors on the mortality and other kind of adverse events on VE ECMO patients. But regarding the rotational atherectomy, we couldn't really manage to do a great and really valuable study yet, but it's in our plans, yes.
I also would like to tackle on this severity of the lesions, or mildly calcified, severely calcified, because it's very evident that sometimes it's not the amount of calcium which is in the vessels or in the plaque, but the location of the calcium. So if it's circumferential, so it's 360 degrees, that really needs rotablation, and that's really just the amount. So that's why I was a little bit puzzled that you had only studies, 2 with IVUS and 1 with OCT included, because that might be, much more important than, just looking at the radiographs.
I can totally agree. Unfortunately, again, we also, I think, not only the circulation and the characteristic of the exact lesion, but the location is, again, really important. We also extracted data on the location, but again, because the absence of individual patient data, we couldn't really manage that. Yes, so on the lesion part, so the circular or other kind of type of lesion, there wasn't really a great data that we could use because of the lack of using intravascular imaging techniques, but it would be really important, yes. So in our department, the practice is that we really try to use these devices and base the decision on what we could see.
The next question comes from you.
Thank you. Congratulate for your presentation. I would like to ask a question regarding your second project. And what kind of unloading devices do you use in your department and why?
Yeah, I will just go back quickly. This figure on the right is from my review article. It shows the A is the IABP intra-aortic balloon pump, the B is the pigtail catheter. This is that we mostly use because it's really it's a cheaper one, but also a quite effective one. It's just a catheter, and we connect it to the circulation of the VE ECMO, and it can help the left ventricular's work. On the C figure, you can see the Impala. Unfortunately, it's not really available in our department, or I don't think we really use them in Hungary because it's really expensive. Maybe in some cases it's an exception. Also on the D, on the figure D, you can see the septostomy, balloon septostomy. We sometimes use that, but mostly we use the B, the pigtail catheter.
Thanks for the presentation. It was a nice presentation. I have a few questions, so I will grab the mic and keep it for a while. My first question is that I'm pretty far from cardiology, but I know that MACE has several kinds of definitions. So it depends on country, depends on many things. So how did you deal with that?
Yeah, thank you for the question. Actually, we came up with our own definition. It was based on the literature and also based on my supervisor's experience, because some of the studies define the MACE differently, but they reported on the individual parts of the MACE that they collected as a MACE, but we extracted data on the individual outcomes of MACE. As I said, acute coronary syndrome, repeated revascularization, in-stent restenosis, stent thrombosis, all-cause mortality. We included all of them in the MACE definition, and we recalculated the MACE for every articles to have a more accurate and poolable data.
So then I don't know if you had any articles, but if you had an article that just said MACE, this number, you drop that article?
Usually they don't report MACE in just the form of MACE. They usually report the parts of the MACE as well. But yes, then we couldn't really use that article.
Thank you. So my next question would be the primary outcome of your first topic. You said that the odds ratio was around 0.6. So you said that the risk was halved, basically. But the confidence interval was between 0.2 and 1.5. So the risk could either be the 0.2 of the other group or 1.5 times as large. So would you, based on only this result, would you change your practice, or would you just be careful
no,
and...
Of course not. So it was great to see clinically, but because it is really not significant statistically, we can't really conclude anything from that analysis. So we should say that there is no difference between the two groups on that analysis. We just wanted to find the cause of that great heterogeneity in the study, and this is why we went further on this analysis. But yes, so we can't really conclude anything from that forest plot or result itself.
Thank you. And my last question is to your second topic. So I've seen that your main outcome would like to be a time to event data, but you chose the 30-day mortality. So why did you chose this 30-day mortality over, let's say, hazard ratio, Kaplan-Meier curves?
Yeah, unfortunately, only I think 2 studies reported on the survival data. So in a form of Kaplan-Meier curve, so we couldn't really extract data on that. Most of the studies included the variables on a dichotomous form, so we could only use the odds ratio.
You mentioned perforation, dissection, and that there are rare events. And I was just wondering, what is the exclusion criteria to enter such a studies? What would be the contraindication to have these devices? Thank you.
Thank you for the question. There are some kind of exclusion criteria or inclusion criteria regarding the angiogram. If we see mostly in a moderate lesion in our department, we not always use rotational atherectomy. Sometimes we only use the cutting balloon or scoring balloon, so the modified balloons that we studied. And also there is another device, the orbital atherectomy, that we could use. Nowadays, it's coming into our country on our everyday lives as well. There are specific lesion characteristics like the location, the type of, we use these intravascular imaging techniques to assess the circularity maybe on the lesion. So it really is a case, so the individual case decides what we should use. Of course, if there is a 3 or so more than 2 coronaries are affected, then we shouldn't really start with the interventional cardiology treatment. We should give the patient a surgery treatment. So it's really important to draw a line. So if there is a 3-vessel disease, then we don't really use these interventional devices.
In your second paper, you included 2 studies on pediatric patients, didn't you? Yeah. And my question is whether these 2 papers really did increase the heterogeneity of the whole group, or not?
Thank you for the question. It's really hard to tell because I will go back to my table. And as you could see, of course, in case of pediatric patients, they mostly use the central VE ECMO, and the other studies mostly included peripheral VE ECMO. So itself, it can be a cause for heterogeneity. Also, the types of unloading devices that they used also differ. And of course, the age of the patients can also differ, and the comorbidities. And also the indication for VE ECMO, it really differs because in the adult population it's mostly ACS or ischemic cardiomyopathy, but in this patient population it's non-ischemic cardiomyopathy or myocarditis. So yes, it's a really great deal. I think we just in the part of data analysis, so I think we will do a subgroup analysis or maybe an omission of these articles in a different analysis to see the difference between the patients.